methods that we use to determine lung volumes. And this is a lecture that is mainly designed to go over how that process works. Now, I will put here that this isn't just my work. Dr. Kadisi, who's a colleague of mine, was kind enough to lend me his lecture, and I used that as part of this and made my own changes and added things, but I'd like to give him at least some credit. And there are several references, but the primary references are these two listed here. Okay, so the outline for the lecture, because we're kind of jumping into the middle, usually I give, these lectures that we give are kind of in a row. We talk about spirometry, diffusion capacity, lung volumes, and then sometimes airway resistance and cardiopulmonary exercise testing. So we'll put some context here for the lung volumes, and then we'll briefly, talk about why they matter. But the majority of the time will be spent reviewing body plethysmography and the principles underlying it. Small amount of time on nitrogen washout because it's a fairly simple process. And then a brief thing on radiological methods and a note on what is normal, what is abnormal, how do we define that as it applies to the results of pulmonary function tests. So the background, the four big categories of pulmonary function testing. First is spirometry, which is the oldest, the gold standard. And spirometry is very simply, you have a pneumotac device which measures flows and pressures, and you can integrate the flows over time to generate volumes. And so you take a breath in and out through it, and you can perform various maneuvers. And it'll tell you something about how much air someone can move, how fast they can move that air, and the profile there. So it does give you a lot of information. Body plethysmography tells us a little bit more, because even when you exhale fully, there is still air left in your lungs. And so the total size of the lungs is something that body plethysmography can tell us. And it can also tell us something about resistance to flow, although that isn't really used very much, at least in our labs, the raw or airway resistance. There's other pulmonary function testing, including diffusion capacity for carbon monoxide, or DLCO. And this is a confusing one as well, but it tells us a little bit about the efficiency of the cardiopulmonary system for exchanging gases. And then finally, the last kind of big thing that we do in the pulmonary function lab is cardiopulmonary exercise testing, which is a fairly remarkable test that measures exercise capacity, total oxygen consumption, VO2 max, and you can really identify the limiting factor in exercise, cardiac versus pulmonary versus metabolic, et cetera. So it's a very useful test in certain circumstances. Now, get rid of that. For today, the main thing that we're going to look at is what is the total lung capacity, this thing here. So what I've put here, this figure is a figure of the lung volumes and the capacities. So this is if you're breathing. So on the y-axis is the volume, total volume, and I guess on the x-axis would be time. So this small up and down here, this is just your tidal breathing. So like what we're doing now, just slow in and out breathing. And the volume of this is small. It's called a VT, which is this here. This is tidal volume. And there are various other volumes and capacities that if you break this picture down. So if you take a full breath in above above, the top of your tidal breathing. This is called the inspiratory reserve volume, which is this one here. And if you exhale fully below your normal tidal breathing, this is called the expiratory reserve volume, or this one here. And the total amount that you can voluntarily move, if you exhale all the way down here, and then you take a deep breath all the way to maximum, this is the IVC, or the inhaled vital capacity here, okay? So this is kind of the largest breath you can take. And there is air left behind. This is the RV, which is somewhere here. Oh, sorry, this is the residual volume, RV here, it looks like. The IVC, which was this part, is here, and the residual volume is here. So this is the residual volume. Again, I don't know how to say this, so I'm just pointing to it here. But this is the amount that's left in your lungs after you fully exhale. There's two more concepts, and they become important in a little bit. So one is this volume. That is, so when you normally breathe, your tidal volume, when you are at your exhalation point here, this line, this volume all the way down to the bottom, so including this and these volumes together, this is called the FRC, or functional residual capacity, which is this here. And one of the reasons this is important is that when we are measuring lung volumes, we have to choose a point at which to measure the volume. And you can imagine that I could say, take a breath into full and hold it, and we're going to measure the volume here. Or you can say, I'm going to take a normal breath to here and hold it, and we're going to measure the volume there, or here, or here. And it turns out that the most reliable place that you can reproduce the volume measurement is at this functional residual capacity here. So if you ask somebody to just tidally breathe and then pause here and do whatever maneuver you're going to do to measure the lung volume, this FRC, functional residual capacity, is probably the most repeatable measurement. And so this is what we measure typically. And then we do a couple of maneuvers to determine these other volumes and add them together to get the total lung capacity. Okay? And I'm going to put that on the next couple slides. But we're going to go back to a little bit of background on lung function tests. And I put this in here just because normally this lecture is given after a lecture on spirometry. So this is, I think, hopefully just a review. So in spirometry, you have this cartoon here, this man that's attached to a pneumatac device. This is a device that measures changes in flow and pressure. And you put a little nose clip on, and the patient can perform various breathing maneuvers. And you'll get a couple of graphs that are generated depending on their airways and lungs. You will have different patterns that can suggest different diseases. And that's a topic for a different lecture. But spirometry is the oldest, the kind of gold standard for pulmonary function testing. Lung volumes, beyond the inspiratory capacity, they're abnormal in a variety of diseases, of course. And the classic things are they're enlarged with advanced emphysema. So you'll have air trapping with advanced emphysema and they have large lung volumes. And restrictive lung diseases where there's smaller lungs. For example, the various interstitial lung diseases can result in smaller lung volumes. And I put, just a very simple set of x-rays up, left to right, On the left, you have hyperlucent, enlarged lungs, kind of a narrow cardiac silhouette. And this is an X-ray of advanced emphysema. In the middle, we have normal lungs. And on the right-hand side here, this is an X-ray of somebody who has pulmonary fibrosis. And you can see all of this scarring in the lungs. This is better appreciated on CAT scan, but this is, clearly a scarred lung. So coming back to this lung volumes and capacities figure, what I have here is I've grayed out a few of these here. So the tidal volume and the full breath, which is here, these are things you can measure with spirometry. But in order to measure the total lung capacity, which is from top to bottom, we need some way to measure the residual volume, okay? Or we need some way to measure the functional residual capacity, which is this volume, with this volume here, and then add to it, the inspiratory capacity or something to get the total lung capacity. So that's the crux of the problem, is how do we find out how much air is left in the lung after you fully exhale? And we'll pretend for a moment that we are able to do it, and we'll go into why in a second. But the way that it's typically done then is, as I mentioned before, the functional residual capacity, this thing here, this point is the most reproducible point. If you ask a patient to do the maneuver, they are most likely to do it to reliably repeat this spot. So this is what's measured typically. And then once you measure it, then we have the patient exhale fully to find out what the expiratory reserve volume is, and then they inhale fully to obtain the inhaled vital capacity. And then you can calculate the residual volume, which is just this minus this, very simple math. And then you add up the residual volume plus this volume here to get the total lung capacity. So this is called the linked maneuver. It's probably the most accurate. It is a little bit difficult for people with severe obstructive lung diseases to do, because when they measure this volume, typically patients don't want to exhale right afterward. They prefer to inhale. But if you can do it, this is the preferred measure. And I'm going to go over this in more detail as we continue. But there is an alternative method, which is an unlinked maneuver. And first, you measure the lung volume at this functional residual capacity. So you have this number. And then instead of exhaling, you inhale all the way. And then you can calculate the total lung capacity as this plus this, okay? And it's slightly less accurate than the other method, but that's okay. All right. A little history. The principles in body plethysmography are very simple, but cleverly applied. And they go back to, I think in the US, we typically call it Boyle's law. But Mariotte, I think, was French, maybe, and had the similar, I think they together had the same ideas. And Dr. Kadisi, I think, has some appreciation for French heritage, so he always puts Mariotte's law. And then one of the pioneers is Dr. Dubois, and this, I think, was in the early 1900s. And he's recognized with significant contribution to developing body plethysmography to measure lung volumes. Now, the apparatus is, so it looks like a telephone box, like a glass wall telephone box. And, the person sits inside of it. The volume of the box is somewhere around 1,000 liters, something like that. It depends on the model. and it has a door, which you can't see here, which opens and closes. So the patient comes in, and when the door closes, this chamber is sealed. And inside the box, there is a pressure transducer here to measure the pressure in the mouth. And there is a shutter, which can close off airflow. And it is placed beyond the pressure sensor, okay, which will be important. And then also inside the box, there is a pressure transducer here that measures the pressure of the gas in the box. And these signals then go to a computer, which does some analysis. So when in use, because these are rigid walls, the box has a known volume, a fixed volume. And that's important, and we'll go over why in a little bit. But this is the apparatus for body plethysmography. So the procedure is kind of outlined as follows. The patient sits in the box. The box is sealed. There is a nose clip on the patient's nose, and the mouth is sealed around this pneumatic device that measures pressure, flow, etc. The patient then breathes tidally for a few seconds, and that's what this portion is here. This is tidal breathing here, okay? And then at this point, the shutter, which is, I'll go back here, this device here that blocks airflow, this is engaged, the shutter is closed. And now the patient will not exhale volume at all, but they are asked to pant. So the patient does a very kind of gentle panting motion, like a against a closed shutter. Now, because the shutter is closed, no air moves, but what does happen is the patient generates a negative pressure with each inspiration against that closed shutter, and the chest expands slightly. And because the chest expands slightly, the volume, the free volume in the box decreases slightly, and the pressure in the box increases slightly. And it turns out, using those 4 pieces of information, you can find out what the volume is in the lung. And that's the, I guess, genius of all the people that worked on this, with a lot of credit to Dubois, okay? And so after this panting procedure is done, the patient, the shutter opens, and then the patient exhales all the way, and then inhales to full, and then exhales. So this is the ideal way that the actual procedure is done. And the key concept to understand and tie this together is that of the shift volume. And as I said before, when you are taking a breath in, the chest and lung volume increases. And that increase in the chest volume and the lung volume is pretty much identical, because the structures, the other structures in the chest, don't really compress at these changes in pressure. So when you take a breath in, your heart, approximately doesn't really change in size. It isn't compressed down. The mediastinal structures, all of these things don't really compress. So the only thing that's changing is really the lung volume when you breathe in and out. Now, obviously, a pressure difference or gradient is needed to move air into the lungs and out of the lungs. And that's just to say that there's a delay between the expansion of the lung and the movement of the air. So when you breathe, the diaphragm goes down, the chest wall goes out a little bit, and the chest expands, and that generates a pressure change on this stressed lung volume. And that pressure change then, after a very slight delay, causes airflow to come into the lungs. and then they reach an equilibrium. So I take a breath in, and then I pause, and I've reached equilibrium. But this small difference between the volume that the equilibrium volume and the volume that is right before equilibrium is called the shift volume. So it's just that very sliver of a difference of volume that generates the pressure to drive the airflow. So this is called the shift volume. And this shift volume is exactly what we are using when they're doing the panting maneuver. So the shutter is closed, and the patient makes very small breaths in and out against a closed shutter, and it causes very small changes in pressure and volume in the lungs, which is exactly this shift volume. Now, Boyle or Mariott's law is a simple concept that we've all learned a long, long time ago, and it can be expressed that the pressure exerted by a gas is inversely proportional to the volume it occupies, if the temperature in the system is constant, and if nothing is entering or exiting the system, if it's a closed system. And the equation form, the pressure times the volume at point 1 is equal to the pressure times the volume at point 2. So if one goes up, the other has to go down. Okay. So applying this to plethysmography, and yes, I think the equations did get converted here. So good. So applying this to plethysmography, remember I said that this procedure involves asking the patient to pant, which means to breathe in and out very small breaths against a closed shutter. And the pressure times the volume at the beginning and end of each of these pants should be constant. So let's say that the initial pressure is barometric pressure, atmospheric pressure, and the initial volume is the volume of the lung. That multiple should be equal to the pressure at the end of each inspiration. And I apologize for the math on the next few slides, but I think it's helpful. So I'll walk through it. If you take a small change in pressure and volume by taking a breath in, then what you're really doing is you have the pressure, which is the barometric pressure, and it drops by just a little bit, delta P, change in pressure, when you take an inspiration. And so that multiplied by the change in the lung volume. So the change in the lung volume is going to be the initial lung volume plus a small change in the lung volume, delta V. So all this is saying is that the pressure at the beginning of the pant and at the end of the pant is the same, okay? And that is an expression of Mariott's law. And the change in pressure, delta P, and the change in volume, delta V, this delta V is this shift volume that we were talking about before, which is one of the key concepts. Now, let's see here. Yes, so I added back some of the equations that were lost here, so hopefully you can follow along here. I don't know if this was in the translation, but so this I've rewritten here. This is the same pressure times volume is equal to the new change pressure and the volume with the change in volume here. And you can see on the diagram, the patient has this device here where there's a shutter that closes it here. And now the patient pants against this closed shutter, and we can measure the pressure. You can see the lungs will go in and out. The chest will go in and out, and of course there will be pressure change. So if I just multiply this equation out, so PB times the volume of the lung, you know, this times this, this times this, this times this, I get this right here, where the initial pressure is equal to this initial plus this change minus this change minus this change. Now, one of the approximations that made is that because the patient is panting at a very, very small breaths, the change in pressure and the change in volume, these numbers are very small compared to the barometric pressure and the lung volume. Because they're each very small, the product of the two of them together is minuscule, and it can be ignored. So this last term, delta P times delta V, this is just ignored and considered to be near zero, okay? What remains is this part here, and you can rearrange this and solve it for the lung volume VL here. So VL, and this is just simple algebra, so I don't show all the work, but take my word for it. If you just rearrange it and solve for VL, you will get at the end the barometric pressure multiplied by this change in volume of the lung divided by the change in pressure, this delta P. And this delta P is, it really is the change in pressure at the lung, but because the patient is breathing against a shutter, the change in pressure at the lung is the same as the change in pressure at the mouth. So what we're left with is the volume of the lung is equal to the barometric pressure multiplied by the change in volume of the lung divided by the change in pressure at the mouth. Obviously, we know barometric pressure. We can measure the change in pressure at the mouth. So now what we're left with is we need to find out how to measure this change in volume of the lung, which is that shift volume that we talked about earlier. And that is what requires the body box. So before this box really didn't play a role, right? But now if you put someone in the body box, I'll kind of summarize it and say that measuring the pressure change in the box will tell us what the change in volume of the lung is. But I'll show you how that works. So the box is a rigid container. And so any increase in size of the chest or the volume of the person requires the exact same decrease in the free volume of the box, V box. And any decrease in pressure in the chest requires the exact same and opposite increase in pressure in the box. Okay? So that's the principle. And now we apply the same Marriott-Boyle's law to the box. And I apologize, I don't think that the equations went through somehow in the PowerPoint, so I added them back at least on the English side here. So I think this probably looks a little bit abnormal on your end, but we'll try and get through it. So the same method as before, the volume of the box is equal to the pressure, barometric pressure, multiplied by the change in volume over the box, divided by the change in pressure of the box. And we know that the change in volume of the box is equal and opposite to the change in volume of the lung during this maneuver. So if we substitute this change in volume of the lung into this volume of the box, then we can insert this back in and obtain that the volume of the lung is equal to the barometric pressure multiplied by the change in volume of the lung divided by the change in pressure of the mouth. So if I substitute this into here, then we get the final relationship, which is the volume of the lung is equal to the volume of the box multiplied by the change in pressure of the box divided by the change in pressure at the mouth. And this is kind of cool. understanding the derivation doesn't matter too much, but what we've shown here is that the volume of the lung is related to the volume of the box, and the change in pressure of the box, the change in pressure of the mouth. So the change in pressure of the box is pretty easy to measure because there is a pressure transducer in the box. And the change in pressure in the mouth is also very easy to measure because there is a pressure transducer there. So the last piece is, what is the actual volume of the box? And there's a few ways that, I put that here, sorry. So the volume of the lung is equal to this. And so the idea, right, is that you can estimate it by measuring this change in pressure in the box and mouth. So what is this volume of the box? V box is the volume that is not occupied by the patient that is sitting in the box. So because it's this telephone booth shape, you can easily calculate the volume of the whole thing, but you have to subtract the volume of the person that's sitting in there. And there's a few ways to do this. You can estimate it based on their height and weight and get a body volume, but that's not preferred. In practice, what is typically done, and what I didn't show, is there's another place where a motor can pump a known quantity of air in and out at equilibrium, and based on that changes pressures, you can find out what the actual volume of the box is. So that's what's done in practice. So take my word for it that the volume of the box then is known, and what you're left with is you just have to measure the change in pressure at the mouth and actually identically the change in volume or the change in pressure of the box. These two are identical. And each panting maneuver, you will generate this line here, this loop. And this loop should be very narrow. And the delta P over delta V, this is a slope. So the slope of this line actually determines what the volume is, okay? So each panting maneuver generates a loop, and the slope of that loop is used to determine the volume according to the formula that we derived. So going back to the procedure again, the patient sits in the box is sealed, there is a nose clip on the mouth, or there's a nose clip, and the mouth is sealed around this pressure sensor. The patient breathes in and out slowly. And then at this FRC point, which again is the place that is the most reproducible, the shutter is closed and the patient pants against this closed shutter. This panting maneuver causes the chest to rise and fall slightly, and the volume of the chest rises and falls slightly. That causes the pressure in the lungs to drop and increase. And there are reciprocal and equal changes in the box. And based on those relationships and the equations shown, we can then find out what is this volume, which is this FRC here. Okay? After this procedure is done, the patient takes a full exhalation and then a full inhalation, and then we're finished with the whole thing. Okay? So that is body plethysmography. And this is the most common way that we measure lung volume. The second most common way is probably nitrogen washout. And when there became kind of ubiquitous nitrogen sensors, this became an easy way to measure lung volume. And very simply, nitrogen in the atmosphere is around 78%. And so nitrogen in the lungs is around 78%. And nitrogen can be washed out of the lungs by breathing 100% oxygen. And let me explain that a little bit more. So if you are inhaling 100% oxygen alone and exhaling via the same valve, then the nitrogen will slowly leave with each breath. So you can imagine your first breath will have a lot of nitrogen in it. Your second breath will have less, third less, fourth less, et cetera, et cetera, et cetera. And if you continue to breathe 100% oxygen, over time, your lung will be washed out of nitrogen because you will end up just exhaling it all. if you can somehow measure the volume, the amount of exhaled nitrogen, and you already know that at the beginning it was around 78% of the volume, then you can just very easily calculate the initial volume of the lungs. It's just, fractions, very simple. So the way that it's done, you put the patient on 100% oxygen, and you have to be attached to a source of 100% oxygen, a series of one-way valves. So you inhale oxygen, and then you exhale here, and you can imagine it that somehow this device would capture the volume, but it's not exactly right. But basically, you have to figure out a way to determine how much nitrogen actually, came out. So this procedure is done over a period of 7 minutes or 5 minutes, and then you could kind of extrapolate. And it's helpful. It's probably easier to do because you just breathe in and out. So patients with severe lung disease that may not be able to do some of these maneuvers, this might be easier. The problem with this is that it assumes that all of the areas of the lung communicate with the airway, because the washout requires that every alveolus communicates with the airway and then is able to be washed out. And you can imagine that if you have significant air trapping, like in advanced emphysema, there are areas of the lung which do not communicate well with the airway and therefore do not wash out well. And it's well known that in advanced emphysema, this method can mildly underestimate the total volume of the lungs. So that's one of the downsides. In practice, the way this works is that there is a sensor that measures the fraction of nitrogen that you exhale. And what happens is with each breath, there is a fraction of nitrogen in that breath measured, and the volume exhaled is measured. And if you take the percent fraction multiplied by the volume exhaled, then you will multiply that, you will get the volume of nitrogen. And with each successive breath, the nitrogen fraction goes down, 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 until it's nearly zero. And you could either go the full 7 minutes to get all the way down here, or you can imagine if you only go 5 minutes, then you know that this is going to be a line that's going to end here, so you can kind of estimate. The equations, the formula, so you do this maneuver at functional residual capacity, basically. So this volume multiplied by the fraction of nitrogen at the beginning, let me go back, which we know is 78%, is going to be equal to the volume multiplied by the fraction of nitrogen at the second point, plus the volume of the nitrogen that has washed out. And what I've included here, there's a very small amount of nitrogen that is washed out from the tissue, which there is a formula to compute what that is over time. And so you can add that in to be more complete. But this is the way that you can calculate the functional residual capacity by this method. There are some technical aspects to this. So nitrogen will leak out anywhere there's a hole. So make sure that there's no perforated eardrums. The patient should be comfortable. Their denture should remain intact. They should have a nose clip on. And you have to wait 30 to 60 seconds to make sure that the patient is rested. And then when they're at a reliable functional residual capacity, they are put on 100% oxygen. And then you watch the nitrogen concentration during the washout, and any sudden changes will indicate a leak. The washout is considered completed when the concentration is less than 1.5%, and you have to do it at least once, but recommended probably twice with good agreement. This can take a long time though, because you have to re-equilibrate. So the procedure itself takes 7 minutes, and then you have to wait for at least 15 minutes and maybe longer if you have severe lung disease to get to equilibrium. And then you average the two measurements, and that's the technical aspects here. So this is an example of a normal nitrogen washout. You just slowly decrease the nitrogen concentration over time. And then this bottom example is an example of a leak. So you can see at this point the nitrogen all of a sudden jumps to almost 80%. So you can tell that somehow the circuit was connected to room air, and it's almost at that 80% here at this leak. So those are the two pulmonary function test methods to measure lung volumes. There are, of course, radiological methods too. Chest X-ray, CT, and MRI have all been used to measure lung size. That's not generally what they're for, but they can do it. Chest X-ray is probably the worst. It's a 2-view X-ray, and compared to body plethysmography, I mean, there is some agreement, but I don't recommend it. CT chest and MRI are both pretty good, but they're very expensive, so they're not really used for this purpose. But if you have a CT chest, then if it is done at maximal inspiration, you can find the volume there. The problem with these methods is generally the patient does not do a maximal inspiration with it, so the volume that you obtain may not be the true maximum. But it is pretty good at measuring the volume that you obtain at the time of the test, because it has 300 slices, and you can calculate the area of each slice, multiply it by the thickness, and you can get that. Now, where it can be come in handy is that you can measure the volume of the lungs independently, so right lung versus left lung, and that can be advantageous if you want to match lung sizes in transplants. So to make sure that the lung will fit properly in the new patient, you can use CT chest to help estimate that. Alternatively, some people measure chests, and there are older methods, but I think CT is probably more accurate. The last bit, so interpreting the data, what's normal and abnormal, and kind of by convention, if you take a normal distribution, then less than the 5th percentile is determined to be abnormal. And obviously, I'm tall. I'm not quite 2 meters, but I'm close. And if you compare me to somebody who is 180 centimeters or 170 centimeters tall, we will have different lung sizes. Similarly, if there's a man versus a woman, a man will tend to have larger lung size compared to a woman. And then different ethnicities have different lung sizes, even for the same height and gender. And that's because body composition can be different. So, for example, African Americans or people of African descent at the same height have a longer legs compared to the total height, which means the chest is slightly smaller. So for the same height, folks of African descent tend to have smaller lung sizes. So you have to find an appropriate population and then generate a normogram. So you compare your results, or the patient's results, to people that are the same gender, the same age, the same height, and the same ethnic origin. And that is a complicated process, but there are a few different databases that can be used to make these normograms. But just remember that you are comparing to these things that are known to affect lung volumes. And then abnormal is considered less than the 5th percentile by convention. Abnormal does not mean disease, but it means the probability of disease is higher because there's less people are going to be just normal and healthy with less than the 5th percentile, but some will, obviously, some will. This is just a representation of the bell curve and the normal distribution. And we have by convention said that less than 5% of the population, either too low or too high, is abnormal. And if you change that to mathematical parlance, that is about 1.65 standard deviations. So 1.65 standard deviations this way or this way is going to be considered abnormal. And the data is probably best established in Caucasians, and the data on lung volumes in non-Caucasians is a little bit harder. We don't have as many data points, basically. But like I mentioned before, in African Americans of the same height, the lung capacities are like 10% lower than in whites or Caucasians. And the reason for that is because of the same height, the leg length is slightly higher, which means that the chest height is slightly lower. And in fact, there are some people that argue that you should measure the seated height, like the chest height, and use that as your reference point rather than your total height. Northern Indians and Pakistanis, again, around 10% smaller than Caucasians. Southern Indians and those of African descent, again, around 12% smaller than in Caucasians. And this is all explained by variations in chest size in different ethnicities. And by chest size, I mean height. So the proportion of the chest height to their total height is what is causing this difference. So in summary, there are several methods that can be used to estimate the total lung capacity. The body plethysmography is probably the best method. That's the one that's most often used. It is a pretty cool application of Marriott and Boyle's law, but you need to interpret the results in the correct context compared to the correct population. And that is it. That's all I've got. Any questions that you guys have?
Thank you, Adam. It's method of plethysmography. I think it's not most popular. I mean, plethysmography of the body. It's not highly, так скажем, presented in our country, but it was so interesting. We have a question from my colleague Yulia Ovcharenko. Please.
Please, yeah.
It's not Yulia, that's her daughter that accidentally logged from her account. But yeah, thank you very much for a lecture. It was beautiful. Thank you very much for that you're doing this for us.
Sure.
It means
Thank you.
the world.
I'm happy to.
Yeah, and sorry for logging from my mom's account. That was rude.
Not a problem. Yes, it's good. It's
Thank
okay.
you.
Okay, and Alina Salagub, please.
Thank you. I wanted to ask about patients. Is there a minimum or like maximum age to who you can perform plethysmography?
No, you can perform it on any age. Plethysmography is not very difficult compared to spirometry. The problems that happen at very old age is that the normal graphs are difficult to generate. So you see here, I mean, each of these graphs has to be generated for, patients that are 65-year-old and woman and height of 5'3". So if you find or height of 160 centimeters. So if you find 1,000 people like that to do lung function tests, you can generate this. If you have an 85-year-old, it's harder to find 1,000 85-year-olds to generate this. And it's almost impossible to find 1,000 95-year-olds. So I think a couple of my oldest patients in clinic, I have a 96-year-old who comes to see me, and she has some restrictive lung disease, and she asks me now, you're not really checking your lung function testing anymore, and I say, well, yeah, I mean, you're doing well, and honestly, I can't compare you to your peers because you don't have any peers. You're 96, so I can generate data, but I can't tell you if it's normal or not because there's just not that many people. So the test, to answer your question, the test is feasible and doable no matter the age, as long as you can follow the directions. That's the only limiting factor. But interpreting the test becomes more difficult at very advanced ages because we don't have a reliable distribution for the really old folks.
Thank you.
Можливо, хтось хоче задати питання, щоб ми перевели його. More questions, please. And okay, I have question. Please tell us indications for plethysmography of the body. No special indications. When in clinic do you use plethysmography for what? In which situations?
So a few things. So both for diseases where you have increased lung volumes. So specifically in advanced COPD is probably the most common. And there's a few things that you can use plethysmography for. So one is you get a sense of how big the lungs are. And if they are really big, let me go back to this X-ray here. There we go. So let me actually, there's two things I want to, okay. So in advanced emphysema here, the lungs are huge. And more importantly, the big part of the pathology, of course, is that when you exhale, you cannot empty out the lungs. They stay big. So there's a lot of air trapped behind. And on this picture here, what changes is this RV. Let me see, I have a better. So this RV, the residual volume here, it becomes enormous. And when it becomes enormous, obviously the lung capacity is big, and it is big because the residual volume is big, because there's air left behind and trapped. So one of the things we use this for is to determine if they are a candidate for bronchoscopic lung volume reduction or surgical lung volume reduction. And that's a procedure where we can go in, and if they meet various criteria, there's a CT scan, you have to look and see. And the idea is you can block off one of the lobes of the lung to collapse it, and allow the rest of the lung to open up and be used better if it is being compressed. So it's used for that purpose. So if they have a residual volume that's like 175% of what's normal, then they may benefit from that procedure. There's more things to do there. A few other things. So in interstitial lung diseases, which like, where is that here? Interstitial lung diseases here where the volume is small. If somebody has unexplained shortness of breath and we get lung function testing, which is non-invasive, relatively cheap, pretty much no risk to the patient. If we see that they have low lung volumes and that they have, for example, low diffusion capacity, which I didn't talk about in this lecture, it will trigger us, for example, to obtain a CT scan of the chest, which is obviously quite a bit more expensive. So in the patient with unexplained shortness of breath, it is certainly something that we will use fairly frequently. Yeah.
Mm-hmm. And so if I understand, like anesthesiologist, yes, this examination we can use for for deciding, solving parameters of artificial ventilation, isn't it?
I suppose you could. We don't typically use it for that, but you could. I'm trying to think for anesthesiology, maybe sometime I can talk about closing capacity. This is something that is very relevant. Obviously, when you induce people and then their small airways collapse and they become hypoxemic. But there's I don't have it on this graph, but there's this entity called the closing capacity, which is the volume at which the small airways start to collapse. And this closing capacity can be higher in patients with obesity, obviously, which is where obese patients, as we all know, you give them general anesthesia and they can desaturate more quickly than people who are, you know, thin and healthy. This is a bigger problem in the US, I think, probably than in Ukraine. We have a lot of obese people here. So, but yeah.
Thank you, Adam. It's so interesting. I don't have experience, yes, with plethysmography, body plethysmography, so it's really interesting, yes, but of course, most popular examination in Ukraine is CT, of course, and spirometry, but not body plethysmography, so interesting. Thank you. Guys, do you have questions, maybe? Yeah, Valeria, please.
Yeah, I want to ask about contraindications for plethysmography.
There's not too many. I mean, because I mean, the main contraindications to pulmonary function testing are if you've had a recent pneumothorax. So, you know, if you have a hole in your lung, you shouldn't be doing these maneuvers where you're taking deep breaths and exhaling. The plethysmography part, though, all you're doing is kind of panting. So, I mean, safety-wise, there's not a lot of concerns. There's all the simple things like, you know, if someone is sick, we don't do it. If somebody has had a heart attack, we don't do it. If somebody has some kind of open chest wound, we won't do it. If somebody cannot follow directions reliably, I mean, this comes up more so in people that have, you know, brain injuries or something like that, where they cannot follow directions. There's very few things that are real contraindications, I guess. I mean, it's a safe thing. It's not a dangerous thing.
Okay, thank you.
Colleagues, students, residents. So maybe we again, yes, answer on our questions. So we appreciate your support, yes, and thank you for your lecture. It was so good.
Thank you very much. Happy to anytime.
Yeah.
Okay, Adam?
Yes.
Adam, before you get off, I just want to confirm with Maria that we are going to have Ben Cowley give a lecture on acute renal or acute kidney injury next week. So is that your understanding, Maria?
Yes, so you plan lecture from Aki for the next week, yes?
Yes. And then
after that, Adam continue lectures according to schedule.
Okay, well, what I was going to ask is, would it be best, if possible, would it be best for you to follow next week's lecture with a renal replacement lecture 2 weeks from today, or does that not really matter to you what order the lectures are given in?
No, do you mean if next time will be acute kidney injury, but after that renal replacement? Yes, you propose. Do you propose?
Well, that's my question. Is that important to you to have the renal replacement lecture given 1 week after the acute kidney injury, or does it not matter?
No, it will be best variant, logical variant, but it's not matter.
Okay, well, I will ask Dr. Cowley whether his colleague, I've not met him, his name is Dr. Duke. I will ask if he will be ready to give a renal replacement lecture 2 weeks from today. And I will send an email to you about that. And Adam, I will send an email to you. Adam, how much more time do you need to get another lecture prepared?
Not much. I think that the way that, I mean, all the lecture topics that I've provided as options are lectures that we give in our conferences. So I can ask, if with more time, I can ask to see if the people that usually give those lectures are interested in giving them. And if they're not, I can modify them or you know, kind of rework them to be my own and then present them. And nobody has had any problems with me presenting any of their stuff. So we have a bank of lectures kind of available, if that makes sense, but they need to be modified so that they can be put into translation form, etc. So, but a week is probably fine. A week is probably fine.
Okay. All right. Well, Maria, I will ask Dr. Cowley whether his colleague, Dr. Duke, can give the lecture on renal replacement 2 weeks from today. And if he can, then we will plan on that lecture 2 weeks from today. But I will send to you an update by email about that. Okay?
Okay, thank you. Yeah, thank you, Jen.
Okay. All right. Well, I'll see you next week.
You too. Thank you.
Okay.
Alex,
All right.
Thank you.
bye-bye.
Bye.
See you next week. Так, шановні студенти та колеги, наша лекція на сьогодні закінчилась. Чекаємо наступного тижня. Отже, кожен тиждень о 3-й годині будуть лекції від наших колег з Оклахоми на різні теми. Буде цікаво.